In this presentation, I want to explain to you that a disease which is as simple as BPH, what are those situations wherein in this disease the patient develops an emergency. He has been a case of BPH, he may or may not be taken treatment for this, but he would develop suddenly some emergency, and you may be an emergency medical doctor on duty and patient comes to you for seeking treatment. In that scenario, how do you understand this problem? How do you diagnose what's going wrong with the patient? How do you investigate these patients? And then how do you handle this emergency in a manner that patient is relieved of agony and his disease is also not complicated? So let's look at emergencies in a patient of BPH and what is your role in this situation. This prostate gland is located below the bladder, and when somebody voids, the gland has to open like a gate and allow the urine to flow out. In some patients, this gland becomes larger and then leads to obstruction to bladder outlet. There may be some amount of residual urinary volume in the bladder left over every time the patient voids. This disease, which is known as benign prostatic hyperplasia, is an extremely common disease in our aging males. The common symptoms of the disease are frequency of micturition, which means the man has to go to pass urine again and again in day, also in night, called nocturia. Some patients develop sudden desire to void and they rush to toilet. Sometimes they start leaking urine even before they can reach toilet. This is called urgency and urgent incontinence. Some patients, when they void, they are not able to project their stream properly. The stream drops down between their feet, over their toes. The force of the stream is also very slow. And when they come out of toilet, they come out with a feeling that they have not emptied the bladder completely. There's something left inside. Sometimes when they go again to pass urine, they have a desire to void, but they cannot start to void. The stream doesn't come, and they're sitting there or they're standing in front of the seat, they're trying to pass urine, nothing comes out. Or if it comes out, it takes time to start. That's called hesitancy. Sometimes patient has finished urinating, he puts his zip up or closes his trousers, and then some drops trickle down in the undergarments. That's called post-micturition dribble. So as you will appreciate that the symptoms of this disease are actually very bothersome and patients are put to trouble. So with these symptoms, sometimes the people feel that they are having aging and these symptoms are the consequence of aging, and they do not seek consultation from doctors. They live with it, they do household remedies, they ask from their friends, seniors, colleagues, what should they do, and they start maintaining their life by regulating their fluid intake, or they're taking all kinds of indigenous medicines till they develop some problem. Essentially, if these patients come to you, in a routine setting, you must remember to do 3 examinations: meatus, the bladder, and rectum for palpating the prostate. These 3 you must check in these patients, and the 3 tests you must remember to do: urine analysis, serum PSA, and ultrasound of the urinary tract. Now this is in an elective situation. But what I am talking to you is in that man who has been willfully avoiding contacting you as a doctor. What may go wrong with him that he suddenly develops an emergency and comes to you for treatment? And then in that scenario, as a duty medical officer, How can you diagnose the disease expeditiously? How can you diagnose which complication is taking place? And how can you do treatment with simple ways, simple methods, without making the misery of the patient worse? Let us first of all see in the urinary system of such a case who is suffering from BPH, what all emergencies can spring up. See, prostate, the BPH, although the disease begins from prostate, but soon it involves the entire urinary tract, the bladder, ureter, kidneys, also the genital tract, the seminal vesicles, and the vas deferens, epididymis, everything. So genital urinary tract gets involved very soon. So it becomes a pan-urologic disease. In that case, you can have emergencies coming up in prostate. For example, patient can come to you with acute prostatitis, and where if neglected, he will develop an abscess in the prostate gland. He can come to you with blood in his semen, and he is really very anxious when this happens for the first time, and if it happens in large amount, he is very worried, anxious. What has gone wrong with me? Why I am ejaculating blood, not semen? Sometimes the emergencies develop in urinary bladder, and this is either infection in the bladder, acute cystitis, and if the patient is having compromised body defense power, he can become septicemic very soon, because patient is having residual urinary volume, and in that stagnant pool of urine, infection occurs. Quickly it gets changed to pus in the bladder, and patient can develop septicemia, particularly if the patient is diabetic. Patient can develop acute urinary retention, and then they have a lot of pain and distress in the lower abdomen. They can sometimes develop hematuria, which is sometimes very severe. The clots form and they block the bladder outlet, and then they come to you again with urinary retention along with consequences of blood loss, the hypovolemic shock. The emergencies can appear in kidneys, where kidney can develop infection, acute pyelonephritis, and again patient can develop abscess if neglected. He can develop septicemia and shock, gram-negative septicemia. In some patients, you can develop renal failure. BPH can cause blood outflow obstruction. Patients develop bilateral hydroureteronephrosis. And in one of the kidneys, if infection occurs, patient develops acute and chronic renal failure. And if that condition is not handled appropriately and promptly, patients can sometimes die. So friends, we look at these, green boxes. These green boxes are telling you what are the likely emergencies that you can have. The red boxes on to your left are showing you at which site these emergencies can happen, and orange boxes on to your right are showing you what can be the consequence if you, as a doctor on duty, do not handle this emergency well. So with this preamble, I'll take you to these emergencies one by one. We will see first of all what happens in the prostate, the emergencies that spring up in the prostate gland. How do you make diagnosis of these emergencies, and how do you treat these emergencies as a doctor on duty? Well, this old man who has been living with some low urinary tract symptoms, with or without treatment, he develops a new set of symptoms. This new set of symptoms are sudden onset pain in voiding or dysuria. He notices that pain. He notices that his stream is now getting more obstructed, much more than what it was a few hours before. He starts getting fever with rigors, and he starts experiencing pain, which is by and large in the area of the perineum or in a perianal area. So pain in perineum, difficulty in voiding, pain during voiding, and some degree of fever, this is something which shakes the morale of the patient. With this new set of symptoms, when patients come to you and you examine, you discover on rectal examination a remarkably tender prostate. This patient is having fever, he looks toxic and looks very distressed with the pain and dysuria and all these things and fever. You do in this patient an investigation, a new test, and this would be trying to diagnose what has gone wrong in the prostate. Is it infection? So you would do urine culture insensitivity. Why has he developed infection? Is he diabetic? You will check his blood sugar. What has happened to the prostate? Is it just inflamed organ, prostatitis, or is it developing an abscess? So you do an ultrasound. So that's how you do slowly build the diagnosis of what is happening in your patient. What I mean here is he developing something what is called acute prostatitis? And if that is the case, how should you treat this patient? Or in fact, first of all, let's see why should you treat this patient? This patient can develop septicemia if neglected. This patient can develop prostatic abscess if not treated with a heavy hand. This patient can surely develop acute urinary retention. So these consequences are very bad. So now you are on the scenario where you have to treat to prevent occurrence of these consequences. What I mean by acute prostatitis is this, that this prostate gland has a complex ductal structure. And when the urine flows through the prostatic urethra, it can reflux through these ducts, and the refluxed urine can go to the farthest end of the prostatic duct into the gland, acini of the gland, as you can see here. And when it goes into this ductal system, every time the patient voids, ducts get dilated because of backflow of urine, right? And once these ducts are dilated, the flow of the fluid in them, the flow of the prostatic secretion in them becomes impeded. And one day, because of the obstruction in the ductal system, because of sluggish flow of fluid in the ductal system, you can develop infection in a part of the prostate gland, and that part swells up. This is called focal acute prostatitis. This can convert into a suppurative condition called prostatic abscess. So you have to therefore know how to manage acute prostatitis in simple scenario. I'm not expecting you to be specialist with it, but expecting you to follow dictum, follow principles. And that principle is, first of all, use a strong antibiotic which can permeate in the prostate gland. And this would be here injection, not oral. And you would use either injection amikacin or some kind of injection cephalosporin, second generation, third generation, or it would be some fluoroquinolone, which is, to my mind, choice here is levofloxacin, because this has highest penetration in the prostate gland. You would of course give him analgesics and anti-inflammatory. Use either of these two, aceclofenac, etoricoxib. Aceclofenac shade better because it has less nephrotoxicity. You work to minimize the congestion in the prostate gland. Ask him to sit in hot tub, or use a hot water bottle to put it over the suprapubic area. This will shift fluid from within the prostate to outside the prostate, and congestion will be minimized. His voiding may improve, his dysuria may improve, his perineal pain may improve. You give him alpha blockers to reduce the stromal tone of the prostate gland. And the drugs that we use currently is either silodosin, this acts in a very quick time, or tamsulosin if you don't have silodosin. So these are 4 approaches that you will adopt to curtail the infection in prostate gland at whatever level it is, and not let it progress to suppurative stage. While you're doing all this, if a patient develops urinary retention, you have to work to drain the bladder. Now here, the methodology of choice should be a suprapubic cystostomy, because the concept is, if you keep a catheter through the urethra and prostate is inflamed, the catheter will increase the pain. Catheter will block the ductal drainage and will cause more problems. So we prefer to have a suprapubic catheter, but if you don't have the facility or you're not trained to do it, you can place a very thin 12 French catheter in an adult urethra. And for a while you keep it, let it drain, and then you can convert this urethral catheter into suprapubic catheter at earliest opportunity. Let's look at the another emergency. Same scenario back again. The old man who was having low urinary tract symptoms comes to you now with a different set of symptoms. And this set of symptom is blood in semen, the amount of which can vary, mild, moderate, severe. A bleeding which he notices after the coitus on his undergarments, or some blood staining there. And when you examine this patient, there's nothing new, because the bleeding has occurred from a disease which is, usually it's a small area disease, and you cannot discover anything in these patients on examination. Investigation wise, of course, yes, you have to examine urine for excluding infection. You have to examine his semen for infection. You have to ask him to undergo a PSA test, because rarely this is a manifestation of cancer prostate. And you must advise him to undergo a cystoscopy to rule out a transitional cell carcinoma or a urothelial malignancy in prostatic urethra or in the area of the bladder neck. So these tests I consider mandatory in anybody who is coming to you as an emergency case of hematospermia. Hematospermia, why should you treat? Why I am saying this is an emergency? Because if you don't handle it well, your patient is going to become cancerophobic. Because blood and semen at this age in a man who is apparently reasonably healthy puts him into panic mode, and he thinks about cancer, nothing else, and he is going to avoid sex for you don't know for how long. He starts avoiding sex because he thinks this is what has led to bleeding, and he avoids this. Hematospermia occurs why? The seminal vesicles, develop some kind of infection. Seminal vesicle is a structure like this. It has small cavities inside it. In the ampulla vas also there are small cavities in it. If you develop infection in these cavities, the infection can lead to bleeding. You can also have hematospermia from a cancerous nodule which is developing in the prostate gland, and it can sometimes cause retention, but sometimes it leads to bleeding. At the time of ejaculation, when prostatic capsule contracts, the cancerous gland is squeezed, and it can lead to bleeding in urethra, coming in semen, and some part of bleeding can go in the bladder and later on come as hematuria. So hematospermia gets followed by hematuria. How should you treat now is the question. The first thing that you should try and do is do something to reduce the prostate vascularity. We have seen that if these patients are given 5 alpha reductase inhibitors, dutasteride or finasteride, their vascularity goes down, and if it is on the prostatic tissue, the blood, then this will be curtailed. I mentioned to you that this can be because of infection, and picking infection from seminal vesicle or prostate is difficult in a clinical setting. You may do semen examination for pus cells and culture for infection, but difficult to document it. So generally we give them broad spectrum antibiotics for a while and see what happens, and the drugs of choice are doxycycline and azithromycin. So with this treatment, give rest to the patient, and gradually these patients improve. We now move on to emergencies which take place in the bladder. Having talked about prostatic emergencies, let's move on to bladder and see what can go wrong in the bladder, and if the patient comes to you with bladder emergency, how do you make a diagnosis and how do you plan your treatment. Another scenario, this old man who was having lower urinary tract symptoms, the new set of symptom in him is sudden inability to void, progressively increasing suprapubic pain, development of a lump in the area of the urinary bladder, and restlessness because he is not able to pass urine. When you examine, the new signs that you discover is suprapubically palpable or percussible bladder lump. And here I would advise you to refrain from doing a rectal examination. In a full bladder, the prostate gland gets pushed towards the rectum. When you put your finger in, you will say prostate is very big. But when you drain this bladder, the prostate will go back to its location, and your assessment, you will say now prostate is small. So actually it is a mechanical displacement of the prostate, not the physical morphological enlargement of the gland. So I suggest that during retention of urine, it's no good sense in doing rectal examination and commenting upon the prostatic size. If you're doing it to discover tenderness in prostate gland, it's a different matter. The new investigation that you should do here, ultrasound to find out how much is the urinary volume here. You must do serum creatinine estimation. You do not know whether this patient has dilated upper tracts, hydrourethronephrosis and renal failure. You do not know his sodium potassium levels. You must do it because once you put the catheter, he may drain a large amount of urine and he may develop subsequently hyponatremia. So baseline information about serum sodium potassium is also important. The key question that you may be having in your mind is, why should one develop acute urinary retention in a scenario of BPH? Now here you look at this bladder and prostate. If the bladder muscle suddenly gets stretched, and this happens because of postponement of maturation. If the old man postpones his maturation because he is busy in a meeting or he is in a bus travel where he cannot stop the bus and void, or he is something, he got altered sensorium for a while and he is not able to respond to bladder call, so bladder gets dilated and distended and patient develops urinary retention. Or else he develops infarcts in the prostate gland. The gland which was about 30 cc before, as a consequence of infarct, it develops sterile edema, swells up suddenly and gland becomes 60 cc overnight. So what was 30 cc while he went to bed and he woke up in the morning with 60 cc of the prostate gland, and his bladder finds it difficult to contract with so much of force that it is able to empty itself across this increased prostatic obstruction. So infarct is a very common cause. You may have infection in the prostate gland which also leads to sudden enlargement of the prostate gland and then bladder finding it difficult to push urine across this swollen prostate. So these are three common reasons why retention occurs. And then why you must treat this condition? Again, I said it's a painful disease. It may put up back pressure on the kidneys, and then if you neglect this urinary retention, patient can develop infection in this stagnant urine. How should you treat this? Needless to say that you have to have what's called urethral catheterization. You have to cover this procedure of catheterization with parenteral antibiotics. Emergency urethral catheterization in patients of BPH is very commonly required procedure, and I'd like to use this opportunity here to tell you that when you decide as a doctor in charge in emergency that this patient, old man of BPH, has retention urine and he needs to be catheterized, it is your sacrosanct duty to also ascertain at the same time that what are the chances that the person who is going to put catheter, if he or she is not you, what are the chances that the technician, the nurse whom you have asked to put a catheter will be successful. So you have to predetermine chances of success of catheterization. This means before you send a patient for catheterization in OR or in a minor operating room setup, examine his penis at least for meatal stenosis and phimosis. If they are present, how will your nurse pass a catheter? Examine the urethra, palpate the urethra for stricture. If there is a stricture, how will the catheter go? So, this is what I mean by saying predetermined chances of success. And not only that, to predetermine chances of complications. What mean this patient can develop after catheterization some hematuria, particularly if he is on aspirin therapy. Many old people are on aspirin therapy these days. Or if the retention of urine is long duration, acute urinary retention, bladder becomes tense and turgid. The moment you put catheter, decompresses it, starts bleeding. Some patients are prone to catch infection as a consequence of catheterization, particularly those who are having foul smelling urine, particularly those who are already having low grade fever, particularly those who have diabetes, uncontrolled diabetes. Some patients are prone to develop spasms in their bladder, particularly those who are anxious by their nature and particularly those who have thick walled bladder. So these are three post catheterization problems that you may have. So it's your sacrosanct duty to see what is going to happen. So you examine the patient. If you find there is a likelihood of complication after catheterization, you must forewarn the patient and also the relatives. Because if that happens, God forbid, if that happens, then you are in good shape. I told you before, you are likely to have it. Don't worry, we will settle it. Okay. During catheterization, you should know that there may be a scenario that your staff is not able to pass a catheter. And now you develop one more emergency. The patient came with urinary retention, one emergency, and you created one more emergency. That catheter did not go in. So what is the reason? The commonest reason is a stricture in the urethra which you did not anticipate. And you have to then probably send the patient for X-ray. This is called retrograde ureterogram, which will show you this kind of narrowing in urethra, and that is the reason the catheter doesn't go easily. Here, for God's sake, don't over try. Ask for specialist help, who would, in this scenario, probably pass a guide wire through the structured area, and over the guide wire he will do some dilatation and then put a catheter, or he may do a suprapubic cystostomy. But you, as a general doctor duty person or your nurse, should not in any condition try and over try to pass a catheter, because you may traumatize the urethra, you may create a false passage, and patient can have torrential bleeding after that from urethra. During catheterization, that's what you can have, urethral bleeding. And this is a bleeding like this, heavy fresh blood coming out from the meatus. This is because of trauma that you created in this patient. Suppose you succeeded in putting catheter and patient's bladder has now started draining urine. Immediately after that, some patients throw rigors, and this is because of infection. And you should know that immediately after rigors they develop fever. So you tell the relatives of the patient, don't worry, he is shivering because of some infection. We'll take care of this infection. This is a rigor, and after the rigor subsides, he will get fever. I give him treatment, patient will be fine. The other problem could be as blood. You put in a catheter, it started draining urine. Initially 100 cc, 200 cc urine came, but now then blood is coming in the urine. And this is something which relatives of the patients are going to get panicky about. Why blood? It's a lot of blood. And mind you this blood can be a minor amount of blood, small amount of blood, or this could sometimes be a large copious blood with blood clots. It can be so bad sometimes. So it's your luck and bad luck what happens. And this hematuria which occurs, can be of this type and will block the catheter, will block the bag tube, and you are in a real soup. You managed one emergency and you created another emergency here. Why this happens? If you look at the bladder has lots of thin walled submucosal or mucosal capillary network. Okay. if you see in a gross picture, that's the kind of arrangement. There's an arteriole on top, the blood flows in, goes through another vessel, capillaries, and goes out through the venule. This is the normal arrangement. But if the bladder becomes full, the capillaries get compressed. Because of stretch, because of increased intravesical pressure, the capillaries become stretched. The blood does not flow well through these capillaries. And as you put catheter and you decompress the bladder, you decompress the pressure, suddenly the capillaries get relieved of pressure and the blood starts gushing into these capillaries, which are thin-walled capillaries. And the blood flows in with a lot of pressure. And because the vessels are thin-walled, they rupture, and as a consequence, there is a bleeding in the bladder lumen, and if there are multiple points of bleeding, there can really be clot formation and catheter gets blocked. The another complication that you can sometimes have, and I think you should forewarn the patient and also the relatives about this, is spasms in the urinary bladder. And this is because, look at this bladder which is full of urine here. If you put catheter, there's a balloon in the Foley catheter. The eye of the catheter is over the balloon. So only that part of bladder will be drained which is above the tip of the Foley catheter, right? There's certain amount of urine around the balloon, peri-balloon. This would depend upon the size of the balloon. Larger the balloon, higher would be the tip in the bladder, right? And greater will be the urine around the balloon. Now what will happen? The bladder is emptied, but certain amount of urine is still present in the bladder. Look that, bladder is emptied, but certain amount of urine present peri-balloon. Now, when this bladder is emptying over the balloon of the Foley catheter, either the tip of the catheter or the balloon of the catheter or the segment of the catheter which is in the prostatic urethra stimulates the sensitive prostatic urethra or sensitive trigone of the trigone, is the antenna of the urinary bladder. When it gets stimulated, patient gets sudden desire to void. He thinks I have to void. And imagine a situation. A man who came to you with inability to void, he was having a lot of difficulty in passing urine. You told, I'll put a catheter, empty your bladder, you'll be fine. You put in a catheter, he drained urine initially, but after 7, 8, 10 minutes he says, I got a sudden desire to void urine. I am not emptying my bladder completely. He got sudden desire to void urine because the trigone is stimulated, because now, and then what will he do? What will the bladder do? Bladder will contract. And as the bladder contracts over the balloon like that, the spasmodic contraction of the bladder will give him suprapubic pain, and the urine that was present by the side of balloon cannot go up and back into the eye of the catheter. It will go by the side of catheter and flow out of the meatus. This is called pericatheteric leakage. This is also called catheter bypassing. The urine will leak by the side of catheter. And imagine now what the patient is experiencing. Patient experiencing recurrent attacks of suprapubic pain associated with desire to void, which is urgent desire to void, and before he could do something, he leaks urine by the side of the catheter. What will he infer? He will think that he is suffering from a blocked catheter, doctor or nurse has not put a good catheter in me, it's a bad catheter, it's a blocked catheter, and he will insist that you change the catheter. It is not a blocked catheter, it's a case of bladder spasm. You do what? You have to, do something to make the balloon smaller, give local anesthetic, give antispasmodic, and then he'll be fine. So the point I'm trying to make is, friends, that this emergency catheterization is not an easy thing to do. You have to, therefore, don't take it casually, and you have to remember certain do's and don'ts. In the do's, take consent. Select a catheter, thinner catheter, 12 French is better, 14 French is okay, but not larger than that. Insist on a very good quality catheter. Give parenteral antibiotics to prevent infection. Have patience while you're passing catheter. Introduce xylocaine jelly Only when urethra is completely anesthetized, then you introduce catheter. Be extremely gentle. If you encounter resistance, stricture, don't overdo, right? And whenever you put a catheter, always do slow, gradual decompression to prevent, sudden bladder decompression and occurrence of hematuria. Pre-inform the patient's relatives and patient about possibility of bladder spasms. If you pre-inform them, then they have a lot of confidence in what you're saying, and then they can support you and they can cooperate with you in the management of this problem. You must watch every patient for at least half an hour after the catheterization, because they can throw rigor attack, they can have hematuria, they can have spasms. So don't push the patient out of your observation as soon as you pass the catheter. Don'ts: never ask untrained staff to do it. Never use old jelly. Never use a previously opened catheter. Never inflate a balloon with saline, because you have to inflate a balloon with distilled water always. If you inflate this with saline, then saline crystals, salt crystals will block the balloon channel. You put the catheter, okay, but then when you want to remove this catheter, the balloon channel will be blocked and you cannot remove the catheter. Never do like this, that insert a catheter, drain the bladder and remove, particularly if the bladder volume is more than 600 cc. So that's about acute urinary retention and its management. Let's see the other situation. Other situation is this man who was having prostatics, low urinary tract symptoms, was doing whatever he was thinking of, some medicine. One day, suddenly, he starts passing a lot of blood and urine, gross hematuria, and he may even pass clots. And these clots may even block the bladder from inside, and patient can have difficulty in voiding. He may even develop frank urinary retention, what is called clot urinary retention. And some patients, particularly if they're old, fragile, not well nourished, diabetics, they can catch up an infection in here. So this is an emergency that way. And when you examine the patient who has come to your care, you have tachycardia, they may have hypotension because of blood loss, they have full bladder lump and they look anemic and pale. What new tests you should do to confirm what you're handling? You must do an ultrasound which will show you clots in the urinary bladder. You must check hemoglobin PCV to know how much blood they have lost. You must also do prothrombin time, activated Paschen thromboplast time, because some of them are on aspirin, some of them are on anticoagulants, some of them are having bleeding disorders. You do not know what they're suffering from, and until and unless you know the cause for this sudden bleeding, you would not be able to manage. So medical legally also, you must document this thing here. So how do you manage this problem? Keep in mind that this is a painful hematuria because bladder is blocked and clots can get infected and can cause obstruction to the outflow of the urine. So this is going to be a real problem and you have to therefore handle it with care. What should you do? You have to give some hemostatics. Maybe you give them tranexamic acid, give antibiotics, catheterize as soon as possible, wash the bladder with saline. If the clots are freshly formed, they are soft and they can be taken away with syringe with wash or the catheter with saline wash. But if the clots are old, they become thick and chubby, they cannot be removed by catheter. In that case, patient has to go to a urologist for cystoscopic clot evacuation as soon as possible. Emergencies in the kidney. Now we move to level 3. We talked of emergency in prostate, level 1. We talked of emergency in bladder, level 2. We are now talking of emergency in level 3 in kidneys. In kidneys, what are those emergencies which you have? How do you diagnose and how do you treat? Same man with lower tract symptoms again develops a new symptom, and this is sudden onset flank pain with fever and rigors, and he says my urine becomes turbid, my urine is foul smelling, yes, and he's passing urine with frequency. And this is the patient who looks to you on examination toxic, febrile. You examine his kidneys, examine his flank, you may discover some edema there, you may discover tenderness there, suggestive of renal involvement. The investigation that you may do, ultrasound, to find out the edema of the kidney, the abscess formation in the kidney, the echogenicity of the kidney, the echogenicity of the urine in the renal pelvis, all that you can know by ultrasound. Send urine and blood, both, for culture and sensitivity. Send blood counts for knowing that if there is leukocytosis, and if yes, what degree it is. And you may, in fact you should here do also a CT scan to know what is actually happening to the kidney. This patient is suffering from acute pyelonephritis, and if time is wasted, he will develop a renal abscess. In that scenario of acute pyelonephritis, why I am asking you to handle this with lot of attention? Because this patient has risk of renal functional loss. Look at the scenario. He is already having some degree of hydroureter nephrosis, back pressure. He already has some degree of interstitial renal damage. If he gets an infection over and above this, his kidney functional loss will be more serious. He can develop septicemia, gram-negative septicemia, and he may actually die because of this complication. So you need to treat this vigorously. Give IV antibiotics. Our choice drugs are one of these, 4: amikacins, third generation cephalosporin, fluoroquinolones like levofloxacin or ciprofloxacin or plurifloxacin, or whatever you can, pazufloxacin, whatever you think is good in your system, your setup, aztreonam, analgesics and anti-inflammatory. Don't give NSAIDs. You want non-nephrotoxic analgesics. And if you discover that the patient is developing or has already developed a renal abscess, you send him for percutaneous aspiration. The another scenario is the same man this time develops a new set of symptoms, and this is nausea, vomiting, some edema on his face and also lower limbs. He is dyspneic because of respiratory distress, some fluid there in the lungs, and because of this he is developing renal failure. And when you now examine him, he is sick looking, his face is puffed, his lungs show cracks, and hypertension is increasing. You subject new investigations, ultrasound, serum creatinine, sodium, potassium, and ECG. ECG because to pick up features of hyperkalemia, right? Ultrasound to show degree of hydronephrosis. Now this is the patient who is now developing acute renal deterioration over and above the pre-existing renal failure. Now this is the scenario in a prostatic obstruction, the hydroureters, hydronephrosis, bilateral increasing hydroureter nephrosis, and then getting infected. And guys, this is the patient with acute renal failure. If you don't treat him, naturally he will develop loss of renal function, and he may develop dyselectrolytemia, acidosis, and will die of this. What should you do? In this scenario, you must try and correct acid-base balance and electrolyte imbalance as soon as possible. Treat hyperkalemia by soda bicarb, calcium injection, catheterize this patient, and maybe you send him for dialysis. Check his fluid status, regulate fluid intake, give him diuretics, give him dialysis to extract extra fluid from his body. Prevent infection by using non-nephrotoxic antibiotics. Friends, that's what I had to share with you, and I thank you for patient listening and watching this presentation. If you have questions and comments, please post it on my email. Thank you very much.